Welcome to the ANNA newly updated CKD modules that address nursing care of the patient with CKD in any setting. I am Leslie Dinwiddie, the project leader for these modules, and today it is my very great privilege to introduce our author and presenter of the second module, Chronic Kidney Disease, Stages 1 through 3, Dr. Jamie Brown. She is the Associate Professor in the College of Nursing at the University of Tennessee's Health Sciences Department in Memphis, Tennessee. And among her many roles in ANNA, she is currently serving as the National Secretary.
So, welcome everyone to chronic kidney disease nursing care for the patient with CKD in any setting. So, I'd like to welcome you to Module 2 called Chronic Kidney Disease Stages 1 through 3. This module is designed for all healthcare professionals who care for patients with chronic kidney disease, also known as CKD, and who want to learn more about who may be at risk for developing early CKD and progressing to kidney failure. I will define the disease, explain how patients are screened, and discuss what therapies can slow this progression. Also, I hope that the information in this module will help you recognize these with or and at risk for CKD. So, giving thanks to, regarding in love and memory of. So, this set of modules, once again, chronic kidney disease, what every nurse caring for the patient with CKD should know, is dedicated to the memory of Miss Sally Burroughs Hudson. She is was a past president of ANNA and a fierce proponent of continuing education for all nurses. So this here, once again, is the second module of the CKD What Every Nurse Should Know series. It is created by the American Nephrology Nurses Association, also known as ANNA, and should be viewed in conjunction with Module 1. So the nephrology nurses who have created these modules, they have done so believing that your understanding of our shared patients and their therapies will enhance our shared care of them and communication between us. If you see an asterisk on a slide, the term will appear in the glossary. So please see the slides at the end of this module for more details. Welcome to the presentation. So here we have 4 key objectives. So these objectives, they're going to basically be guiding this module on the early stages of CKD. As a result of this module, as you can see, the learner will be able to identify the pathophysiology, lab values, and clinical presentation used to identify stages 1, 2, 3A, and 3B. Also, describe the risk factors and the incidence and prevalence of the most common causes and comorbidities of CKD. Discuss CKD outcomes identified in clinical practice guidelines for stages 1, 2, 3A, and 3B, and those treatment options. And then lastly, outline the patient education that's going to be necessary to slow the progression of CKD and manage those early complications. So, looking at regarding physiology review, it can help one understand the pathophysiology of kidney disease. Plus, we know that healthy kidneys, they're going to be our major controllers of urinary elimination. So, the kidneys, they help to do a whole lot of things, such as they maintain homeostasis by removing extra water and metabolic waste from the blood and excreting them in the urine. So this here is going to serve to regulate body fluid volume and osmolarity. Also, the kidneys, they're going to regulate the range of serum electrolytes, such as sodium, potassium, chloride, and bicarbonate. They're also going to contribute to fluid and electrolyte balance. They're going to be playing a pivotal role in maintaining the body's acid-base balance, which is going to be supporting the body's buffer and respiratory systems. Plus, we know that the kidneys, they're going to secrete 90% of the hormone erythropoietin, which signals basically the bone marrow to produce red blood cells, preventing anemia. Also, calcium and phosphorus. Regulation is going to help to build and maintain these strong bones. And the kidneys are going to produce vitamin D3 to aid in the absorption of calcium from the gut. And then lastly, the kidneys are going to be instrumental in excreting drugs and other toxins from the body fluids through the patient's urine. So here kind of also shows the following lab tests are going to be often the first indicators regarding changes in kidney function. So the urinalysis test, also called a UA, is going to contain the following indicators. So looking at the labs or the patient's UA, the color of the urine we know is going to be normally yellow, okay? However, if urine, let's say, is very pale yellow, it's going to indicate that this patient's urine is dilute. Yet, if the urine, let's say, is dark amber, it's going to indicate here that the patient's urine is concentrated, keying and letting us know, hey, this patient here, they're going to be dehydrated. If the urine is cloudy, that's going to be an alert regarding, we have an infection going on. Dark red or brown urine, it's going to indicate blood in the urine. Brown may also indicate increased bilirubin level. Red may also indicate the presence of myoglobin. Other color changes in the urine, they might be actually a result of the patient's diet or the drugs that the patient may be taking. Also looking at, let's say, specific gravity. It's going to be the ratio of urine osmolar density, to water density, which is going to be 1.000. So the normal range for the specific gravity of urine is 1.015 to 1.025. Higher than normal concentrations are often a result of dehydration. And then also looking at lastly, we're going to say the patient's UA. pH is going to measure acidity. A normal pH range for urine is going to be 4.5 to 8. Abnormal pH values are going to indicate kidney or a urinary tract disorder. So also moving on next, we can see that regarding a normal urinalysis, glucose should be negative. So normally glucose in the urine is going to be too low to be detected. So any detection of sugar on this test is usually calls for a follow-up testing, especially regarding diabetes. Also, urine should be negative for ketones. So any amount of ketones that are going to be detected in the urine could be a sign of diabetic ketoacidosis, also known as DKA. It can also be indicative of starvation, prolonged fasting, or vomiting, and it's going to be definitely requiring follow-up testing. So urine should also be negative for blood. So red blood cells or any other blood components in the urine, they're going to be a sign of kidney damage. It could be a sign of infection, kidney or bladder stones, blood disorders, or other conditions. Menses may also cause a false positive for blood in the patient's urine. Also regarding urine, it should be negative for protein. So positive results require further testing for diagnostic purposes. However, there is a potential for false positives. So therefore, an early morning sample is preferred to limit the likelihood of any false positive results regarding the patient's urinalysis. Also, urine should be negative for bilirubin, which is going to be a product of red blood cell breakdown. Bilirubin in the patient's urine can be indicative of liver damage or disease. And then looking at lastly on the slide, as you see, non-trace and leukocyte esterase, they're going to be products of white blood cells. So if either one of these, let's say, is detected in the patient's urine, it's going to be a sign of a urinary tract infection, also known as a UTI. So here, as you can see, also shows the patient's CBC levels. So regarding hematocrit, so here you see it's going to be circulating volume of RBC. So normal hematocrit is going to be basically ranging from 36 to 46%. Hemoglobin is normally 14 to 18 in males. And as you see for females, it's going to be 12 to 16 regarding that population. So looking at next regarding the patient's basic metabolic profile, also called a BMP, which is also called the complete metabolic profile. So looking at it in detail, so the serum creatinine and the blood urea nitrogen, also called the BUN levels, they're going to be indicative regarding metabolic waste products in the bloodstream. So the normal range for serum creatinine is going to be 0.5 to 1.2. Males typically they're going to have higher muscle mass than females, so their levels are actually going to be higher range than normal. Regarding, let's say, the normal range for BUN, it's going to be 10 to 20. Electrolytes are also measured in a BMP, such as potassium, sodium, chloride, and bicarbonate. So those values are going to be going to be potassium 3.5 to 5, sodium 135 to 145, chloride 96 to 112, and bicarbonate 19 to 32. Also, we know that CKD is going to disrupt the balance between calcium, phosphorus, vitamin D, and the parathyroid hormone. So kidney disease is going to affect the kidney's ability to produce the active form of vitamin D, which basically inhibits the body's ability to absorb dietary calcium. So the normal range for calcium is going to be 9.0 to 10.5. Phosphorus is going to be 3.0 to 4.5. Vitamin D range is going to be 30 to 85. And then lastly, parathyroid hormone will be 7 to 84. So lastly, also looking at regarding diabetes, is going to be, as we know, the leading cause of kidney failure. Therefore, glycemic control must be examined. So the normal range for a fasting serum glucose level is going to be 70 to 99. So this slide here, as you can see, is going to list the major elements that need to be included in a general screening. So screening, as you know, is an assessment technique used to identify dysfunction in individuals who may be at risk for kidney damage and progressive CKD. A screening, it should begin with a person's health history. For example, think about people who may have diabetes, hypertension, cardiovascular disease, metabolic syndrome, or a family history of those diseases. They should be screened. Additionally, we know that screening should include childhood diseases, major surgeries or trauma, current medications, and allergies. Screening should also include, let's say, the patient's age, especially, let's say, your older age patients, and also the patient's ethnicity, especially African Americans, Asians, and Hispanics. Screening measurements and labs and tests should also be done because, hey, we know that any abnormalities call for retesting and follow-up testing. So the definitive tests regarding the potential for CKD and the estimated glomerular filtration rate, also called your EGFR, and the urinary albumin to creatinine ratio, also called your UACR. So, talking about the glomerular filtration rate, it's going to be an estimate of the quantity and the speed at which the kidney filters blood and has long been considered the best measure of kidney function. So, if the GFR is significantly less than normal or in conjunction with kidney damage, it is used along with other markers to calculate the staging and the severity of kidney disease. So to estimate GFR, which is going to be a mathematical formula using values regarding the patient's age, their race, gender, and serum creatinine, is going to be used regarding this calculation. So the formulas recommended by the National Kidney Foundation are from the current clinical practice guidelines and can be found on the website of www.kidney.org. So also looking at still kidney function labs and everything. So microscopic urinalysis is going to be necessary for diagnostic and staging purposes. So urinary dipsticks, they can detect red blood cells, neutrophils, eosinophils, and bacteria. They cannot, however, detect tubular epithelial cells, fat or CAS, crystals, fungi, or parasites. However, examination of urinary sediment is needed to detect these things here. So also, we know that red blood cell cast in the urine may suggest glomerulonephritis as the cause of hematuria. Also, albumin and creatinine quantification in a lab urinalysis is necessary for determining the albumin to creatinine ratio, which is going to be essential for diagnosing and staging. So looking at urinary albumin, it's going to be our key marker for CKD along with GFR. So albuminuria is going to be used to diagnose and monitor kidney disease. A change in albuminuria may reflect a response to therapy or a risk for progression. A decrease in urine albumin may be associated with improved renal and cardiovascular outcomes. So the Kidney Disease Outcomes Quality Improvement Work Group, also known as KDIGO, they prefer using the albumin to creatinine ratio, called once again the ACR, for the most accurate measure. So a spot urine albumin to creatinine ratio is used to estimate a 24-hour urine albumin excretion. The UACR is going to be the ratio between two measured substances, urine albumin and urine creatinine. Albuminuria is going to be when the patient's UACR is greater than 30 albumin per gram of urine creatinine, and it's going to be a marker of CKD. Patients at risk for CKD, such as, let's say, for example, diabetics, they should have urine albumin excretion assessed yearly to diagnose and to monitor kidney damage. So the more frequent monitoring may be indicative regarding patient with change in clinical status or after, let's say, a therapeutic intervention to determine the change in the stage of the patient's chronic kidney disease. So you may have heard of the 5 stages of CKD. However, in 2002, kidney disease was classified into 5 stages based on the level of kidney function, progressing from stage 1 to stage 5, according to the DOKI CKD qualifications. If any abnormalities were noted in stages 1 or 2, additional testing would be ordered to identify the disease process and the amount of kidney damage. However, since the 2002 CKD classifications by stages was published, new information now has emerged on albuminuria and GFR and their association with mortality and other outcomes in the patient. So also in 2012, due to the worldwide epidemic of CKD, the KDOKI clinical practice guidelines, following a decade of research, were updated and revisited with some modifications in the staging to reflect the incorporation of the UACR. So looking at, let's say, details of this update, they can be found in the 2013 Kidney International Journal supplement titled Kidney Disease, Improving Global Outcomes, KDIGO, 2012 Clinical Practice Guidelines for the Evaluation and Management of Chronic Kidney Disease, or online at www.kdigo.org. So this document here is going to aim to provide state-of-the-art guidance on the evaluation, the management, and the treatment of all patients who have chronic kidney disease. So specifically, the guidelines that we know, they're going to retain to the KDOKI definition of CKD, but it's also going to be present an enhanced classification framework for CKD. So KDIGO defines chronic kidney disease as abnormalities of kidney structure or function that have been present for more than 3 months. Once again, 3 months. And it's going to have implications for that patient or for that individual's health. CKD, Going to be classified based on cause. Glomerular filtration rate, also once again known as GFR, category, and albuminuria category. So here, as you can see, the National Kidney Foundation, they have endorsed the recommendation that CKD be classified by, once again, cause, GFR category, and albuminuria category. This is now collectively referred to as CGA staging. It's going to represent a revision of the previous KDOQI CKD guidelines, which included staging only by GFR level. So this chart here, it illustrates, as you can see, KDIGO staging, which considers GFR and albuminuria. Introduced once again, like I mentioned before, in 2012 and updated in 2024. So the KDIGO staging would be the basis for subsequent discussions of the progression and symptomology of CKD in this and other modules moving forward. This will also be our basis for other slides. They're going to be explaining the staging of the progression and the symptomology of CKD. Also of note, it's going to be a difference in the KDIGO staging of GFR, with stage 3 being divided into 3A and 3B, which will be discussed later. The visual presentation also, as you can see the color changes in this graph, they're going to be emphasizing the presence of protein in the patient's urine in sufficient quantities, changes regarding the level of risk for progression, and also the severity of prognosis regarding CKD. So as you can see, green here is going to be showing low risk. Basically, no other markers of kidney disease, no CKD. However, yellow, moderately increased risk, orange, a high risk, and red, a very high risk. So once again, albuminuria is going to be the presence of albumin in the urine, and it's going to be considered abnormal if greater than 30 milligrams per gram. So looking at this here, as you can see in both stages 1 and 2, the GFR is going to be over 60 milliliters per minute. The patient's blood pressure and their serum chemistries may be in the normal range, especially in the absence of a comorbid disease such as diabetes and also cardiovascular disease. However, though, the patient may be at risk for the progression to further stages due to some structural or urinary abnormalities, such as the presence and degree of albuminuria. Okay, so looking at stages 1 and 2 of CKD more closely. The visual of these categories of CKD, as you can see, shows that green A1 means the patient is once again at low risk. And if there are no other markers of kidney disease, there is CKD. As I mentioned earlier, the yellow shaded category means that these patients with normal or mildly increased GFR are going to be having moderately increased albuminuria and a mildly increased risk of progression. Those, however, with a severely increased albuminuria, definitely say shaded in orange, going to be having greater than 300 milligrams per gram of albumin in their urine, and now going to be at high risk for the progression of kidney disease. So patients basically known to have diabetes or high blood pressure. As we know, the two leading causes, once again, of kidney damage and the progression to kidney failure, if not treated and controlled, are at the maximum risk of progressing to stage 5 kidney failure. Also, we know if the patient has a family history of kidney disease, such as polycystic kidney disease, a history, let's say, of those urologic disorders indicating an infection or kidney stones, or has elevated lipids. Also, looking at thing about acute injury. acute kidney injury, also known as AKI, from drugs, toxins, and infections. Also, we know, hey, regarding exposure to nephrotoxic medications such as antibiotics, NSAIDs, NSAIDs, diuretics, chemotherapy agents, and radiocontrast agents. As we know, many people they think that hey, just because I'm taking an over-the-counter med, that they are safe and can be taken at any time, let's say for minor pain. However, we know that these medications, such as ibuprofen and other NSAIDs, can lead to further loss of kidney function. So, therefore, it is important to remember that reducing the dose of some of these medications as the patient's kidney function declines is going to be important to avoid additional damage to kidney function. Also, patients diagnosed with kidney disease should remind their healthcare providers when prescribing medications as they may need a reduced dose due to loss of kidney function. Also, looking at this here regarding the bullets, you see that dehydration and volume depletion are also key risk factors. Also, that the healthcare provider must be aware, perform appropriate testing, and educate the patient. It is also important to remember that during stages 1 and 2, most patients will have no symptoms. However, the healthcare professional must identify those patients who are at risk for CKD and slow progression regarding to maintaining quality and quantity of life. So here looking at say stages 1 and 2. As you can see, care going to be focusing on establishing the diagnosis of CKD and treating the cause of the kidney disease as indicated. For example, steroids. They may actually be used to treat some glomerular diseases. Also, one must identify and treat any comorbid conditions, especially those, once again, that is going to be affecting kidney function and begin to implement strategies to delay that progression of kidney disease. As previously mentioned, uncontrolled diabetes and hypertension, they're going to hasten the progression to kidney failure. Therefore, once again, early and aggressive management of these diseases may delay the progression of CKD. Since we know cardiovascular disease is prevalent, it also we know any intervention to reduce cardiovascular risk is going to be recommended. A key priority should be laying the foundation for partnering with the patient to manage the patient's care. So also looking at say regarding tests and studies. So many tests and studies may be required to properly diagnose and treat the cause of CKD. So an ultrasound of the kidneys is going to be one of the most common non-invasive tests used to examine the general structure of the patient's kidneys. And ultrasound is going to be used having high frequency sound waves, going to be transmitted through the kidneys to detect abnormalities. Plus, we know it's going to be providing general appearance of our patient's kidneys, their size, etc. Related to size, small kidneys, they may indicate chronic disease, and larger kidneys may indicate tumors, infiltrating disease, or nephrotic syndrome. Doppler integration may reveal venous thrombosis or arterial stenosis. And intravenous palliagram, also known as the IVP. It may be useful regarding identifying kidney asymmetry or abnormalities in the patient's kidneys, such as stones, tumors, or scars. These tests also involves using contrast dye, which we know once again, contrast dye is a nephrotoxic drug, and it can also decrease kidney function. So the KDIGO CKD 2012 guidelines, they provide actually specific interventions to prevent IV contrast kidney damage. So, a computed tomography, also called a CT, It's basically going to construct an image of the patient's kidneys from a series of cross-sectional slices that are then translated by a computer. A CT scan is going to be our gold standard for detecting kidney stones, but also may reveal a renal artery stenosis in addition to, let's say, obstruction or tumors. A CT with contrast, it may show sites of renal artery stenosis. Contrast, induce acute kidney injury. CI, AKI, is going to be our risk regarding the procedure because, hey, it's involving that contrast administration, such as, let's say, a CT scan with contrast dye. Another test, such as an MRI, it may detect mass lesions, renal vein thrombosis, and also cysts. A nuclear scan may also be used regarding injecting a radionuclide. So a nuclear scan is going to be useful regarding showing asymmetry of the patient's kidney size or function, functional evidence of renal artery stenosis, acute pyelonephritis, or scarring. So looking at, let's say, a percutaneous kidney biopsy, it's going to be the needle excision of a core of the kidney tissue to obtain a specimen for histological examination. This is only performed when there is doubt about the cause and the extent regarding kidney disease. A kidney biopsy is going to be differentiates, let's say, glomerular from tubular disease. It's going to also be differentiating between stages among certain diseases, such as lupus. It's going to be monitoring our patient's progression, or it can be assessing regarding, say, the patient response regarding, let's say, medical management or therapy. So we know regarding a kidney biopsy, we know it is going to be an invasive procedure and can have significant adverse events. One primarily is going to be bleeding. Also, we know a kidney biopsy is going to be contraindicated in patients with kidney tumors, bleeding disorders, reduced blood volume, severe hypertension, hydronephrosis, solitary kidney, or advanced kidney disease. So, as I've pretty much have said quite a few times, we know diabetes, the primary cause of CKD, because the long-term damage of uncontrolled diabetes is going to be a microvascular disease leading to gastrointestinal, cardiovascular, peripheral, arterial, cerebrovascular, retinal disease, and nephropathy of CKD. So, the goal for people regarding CKD, regarding, let's say, their glucose level goal, we're trying to maintain a blood sugar glucose level in the range of 70 to 99. The patient should also be physically active and achieve and maintain a healthy weight and also adopt a healthy lifestyle and dietary habits to prevent high and low blood sugar reactions. So the KDIGO guidelines recommend a hemoglobin A1C target of 7.0% to prevent or to delay the progression of CKD. This here, it will decrease the microvascular problems associated with diabetes, such as retinopathy, neuropathy, nephropathy, and those microvascular diseases. Using an angiotensin, let's say, converted enzyme inhibitor, pretty much called an ACE, or an angiotensin receptor blocker called an ARB, statins, and also antiplatelet therapy, were clinically indicated, can also be used regarding those types of things. Also, we know that adults with CKD and diabetes must have a regular assessment by their podiatrist. Also, guidelines recommend that metformin be continued with patients who have a GFR greater than 45, which is basically stages 1 through 3A for glycemic control. Patients must also know that infections and steroids may affect their blood sugar level, and they're going to need very, very close monitoring. So, as I've discussed, diabetes is going to be causing cardiovascular disease with the symptom of hypertension. But remember, primary hypertension is also the second leading cause of CKD, and its management is going to be very crucial to delaying the progression of CKD. The recent image from the American Heart Association shows the various blood pressure guidelines and categories and the stages of the severity of, let's say, hypertension. So, with regards to hypertension of CKD, the KDIGO work group promotes an optimum healthy lifestyle for individuals with CKD to delay its progression. So, as basic definition, we know that hypertension is going to be defined as a uh, basically repetitive elevated blood pressure level that's going to be exceeding 130/80. So, as my patient's kidney disease progresses, let's say through uncontrolled hypertension, physical changes begin to occur in the patient's kidney, further increasing blood pressure and managing the nephrons that basically filter these waste products from the patient's blood. So, as we know, blood pressure management is going to be very complex and multifactorial. So, the collection and say of the patient's history, including their modifiable risk factors for hypertension, such as weight, salt intake, smoking, and alcohol use, should be assessed early. Edema may also be treated with diuretics, and sleep apnea should be ruled out as a cause of hypertension. So, looking at now, as with any assessment, multiple measurements using the same method and in the same setting are going to be necessary to confirm the diagnosis of, say, of hypertension, whether in the office or at home. An automatic BP cuff or device is going to be recommended. So the guidelines that you can see advise that to get the correct measurement, that first of all, no talking or use of a smartphone during the procedure be done. No exercise, nicotine, or caffeine for at least 30 minutes before measurement. Removing clothing covering the location of, let's say, the blood pressure cuff. The patient needs to be seated comfortably with legs uncrossed and back and arms supported for at least 5 minutes prior to measuring. Verify that the patient's cuff size is correct. Middle of the cuff should be placed at the level of the right atrium. And then lastly, we know an average of 2 to 5 measurements at intervals of 1 to 2 minutes. Additionally, if the patient, let's say, blood pressure, let's say, is elevated, we're going to repeat these steps, taking the blood pressure on the patient's other arm. So, keeping in mind, we got to remember that hypertension is both a cause and a complication of CKD. Blood pressure control is going to be an important strategy to delay kidney progression. Plus, we know that blood pressure goals are going to be dependent on the degree of albuminuria, regardless of, let's say, the patient's diabetes status. So the goal is going to be less than 140/90 for those who have albumin, say, in the urine, under 30 milligrams in 24 hours. Goal gonna be less than 130/80 for those that say who have, let's say, albumin in the urine, greater than 30 milligrams in 24 hours. An ARB or ACE may be used for patients with diabetes and albuminuria of 30 to 300 milligrams in 24 hours, while an ARB or an ACE may be used for patients with and without diabetes who have albuminuria greater than 300 milligrams in 24 hours. So these antihypertensive meds, like I've just mentioned, they're going to be key to delaying the progression of kidney failure through the reduction of albuminuria. Depending on the patient, other antihypertensive medications such as beta blockers, calcium channel blockers, and diuretics may also be required for successful blood pressure reduction. So this slide here, it basically shows the recommendation summary for blood pressure management, because I know that the print is pretty much difficult to read, this chart can be downloaded as a PDF. So let's say talking about blood pressure or hypertension management. So there are many options for treating blood pressure. Every effort should be made to make the treatment regimen as simple as possible for the patient. Plus, we know often patients are going to be prescribed medication without fully grasping, let's say, the necessity of the actual therapy. Therefore, any concern should be addressed, let's say, with the patient's provider. Also, we know that the number of medication that a patient with CKD can may take can cause or may cause a financial burden on that patient. Also, other medication related, let's say, issues regarding to consider going to be the patients to discontinue the medication regimen because, hey, they're simply having to say the perceived or real side effects, such as sexual dysfunction. Also, we know some patients may be using over the counter medications or illicit drugs, which may also impact blood pressure. Plus, we know that patients may also need to make dietary changes, including reducing sodium intake and fatty prepared foods. Also, with that, a dietary consult may also help the patient when it comes to, let's say, maintain their healthy eating habits. Therapy, once again, though, as you can see, it must be patient focused and patient and provider goals must be congruent. So, hypertension, it is not only symptomatic of CKD, but also of cardiovascular disease, also known as CVD. So, cardiovascular disease is going to be our leading cause of death in patients with CKD. So, the risk is going to be increasing as the patient GFR declines. And when microalbuminuria is present, additionally, there are going to be CKD specific risk factors going to be associated, let's say, regarding more advanced CKD, which is going to be driving, let's say, the higher risk of mortality and morbidity, even let's say at the younger age. So people with CKD, they're going to be more likely to experience cardiovascular events than to progress. And then to progress, we're going to say end-stage renal disease. They're going to be having a worse prognosis with a higher mortality. After an acute myocardial infarction, also known as an MI, and we're having a higher risk, we're going to say a recurrent MI, heart failure, and sudden cardiac death. So all people with CKD, they should be considered at increased risk for cardiovascular disease. As previously mentioned, management of those modifiable cardiovascular risk factors, such as improving, let's say, the patient's blood pressure and diabetes control, they're going to be helpful regarding reducing CKD progression. So here we see dyslipidemia. It's going to be common in patients with CKD. It can occur early in the disease process. It's going to be any abnormality regarding in plasma lipoprotein concentration or composition associated with an increased risk for cardiovascular disease. So adults who have been recently diagnosed with, say, with CKD, they should have a lipid profile measure. It's going to be including total cholesterol, low density lipoprotein cholesterol called the LDL, high density lipoprotein called the HDL, and then also triglycerides. In addition, a lipid profile should be measured when the patient has been fasting. The patient may also be referred to a specialist for further evaluation if abnormalities are therefore identified. Follow-up measurement is not recommended, however, unless there's a change in management. Looking at this slide, we see that dyslipidemia can be caused by numerous medical conditions and medications. So moving on regarding dyslipidemia management. So the majority of CVD is going to be caused by risk factors that can be controlled, treated, or modified, such as high blood pressure and cholesterol. Elevated serum cholesterol is going to be increasing the risk for heart disease and for increasing the risk of stroke. Overweight and obesity, as well as dietary consumption of those high amounts of saturated fats, trans fats, and sodium, with decreased consumption of fruits, vegetables, and fish, are going to be linked to an increased risk of a cardiovascular event or disease. Tobacco use going to be responsible for nearly 10% of all CVD deaths, so basically cardiovascular deaths. And it's going to be insufficient physical activity is going to be our fourth leading cause factor for mortality in the general population. So, speaking of lifestyle, efforts to institute lifestyle changes should be first line therapy unless lipid profile is severely elevated. Lifestyle recommendations for people with CKD are going to be not to smoke. We want to make sure our patient is engaging in physical activity, is going to be compatible with cardiovascular health and tolerance. So, basically, trying to aim for at least 30 minutes 5 times per week. We're trying to achieve and maintain a healthy weight with a goal of a BMI between 20 and 25. And we're also trying to adopt a heart healthy diet. However, if the lipid profile, let's say, is severely elevated, lifestyle changes and drug therapy should be started simultaneously. So, successful cholesterol management is going to be important to improve the cardiovascular outcomes for patients with CKD who should be considered in the highest risk category. Evaluation of dyslipidemias should occur at presentation with CKD after a change in status and annually. Drug therapy. It should also be used for patients with LDL between 100 and 129. After a 3-month trial regarding those lifestyle modifications, initial drug therapy for high LDL should be with a statin. Fibrates may be used in patients with CKD for triglycerides at above 500 milligrams per deciliter and for triglycerides at above 200 milligrams per deciliter, with non-HDL cholesterol at or above 130 milligrams per deciliter and who do not tolerate statins. Low dose aspirin therapy, if applicable, it may be added to prevent clotting. And then we're going to say the patient's labs, liver function tests, we need to be doing it before the initiation of a statin, as we at recommended intervals. Plus, we know that the patient's lipid profile should also be monitored regarding response to therapy. So guidelines suggest basically that patients with diabetes and declining kidney function may develop hypoglycemia due to prolonged half-life of insulin in circulation and decreasing appetite. So medication should be adjusted as necessary. While obesity, as we know, is going to be a risk factor, patients need to eat well to thrive. Calorie intake should be adjusted to promote that ideal body weight, and food choices should be made to promote well-being. In adults, to say, who have diabetes, or those to say without diabetes and with a GFR less than 30, protein intake should be reduced to 0.8 grams per kilogram per day. So adults with CKD, once again, they are going to be at risk for progression. So therefore, they should avoid a high protein intake greater than 1.3 grams per kilogram per day. Sodium, it should be reduced to less than 2 grams per day. Saturated fat intake, it should be lowered in fish and vegetable or nut oils, especially those mono unsaturated oils, and those containing omega-3 acids should be increased concurrently. And then let's say regarding dietary fiber, especially say in whole grains, it's going to be our key regarding lowering that LDL. So also talking about care. So care should be taken to identify those nephrotoxins. even let's say during the early stages of CKD. This is going to be including, let's say, those over-the-counter drugs, especially, let's say, those NSAIDs. So think about, let's say, those ibuprofen and things, taken, let's say, for pain. Also, we know that close monitoring of kidney function, maintaining, let's say, adequate hydration, and limiting NSAID use whenever possible are going to be some of those key interventions that may be basically employed in those patients at risk. Also, herbal remedies, they must be avoided due to those unknown contents and the potential for nephrotoxicity. Patients should also receive those appropriate immunizations, such as, let's say, those yearly flu vaccines, and also, let's say, the hepatitis B immunization. Patients, let's say, with both CKD and diabetes, they're going to be at even a higher risk. So, therefore, for them, we know that systemic infection can cause further damage to the kidneys, and also need to remind the patient to prevent infection. They should wash their hands thoroughly and also wash uncooked foods. So, prescribers. So, they must also consider the GFR when dosing any drug excreted via the kidneys to ensure good good medication management and patient safety in the patient who has CKD. So, regarding, say, guidelines that the healthcare provider needs to recommend and think about, are going to be temporary discontinuation of potentially nephrotoxic drugs excreted via the kidneys in people with a GFR less than 60, which basically includes GFR stages 3A and 3B, and those who have a serious intercurrent illness that's going to be increasing their risk of acute kidney injury. Also, keeping that in mind, think about those agents basically going to be included but are not limited to the renin-angiotensin-aldosterone system, also called like your RAS blockers, such as your ACEs and your ARBs, NSAIDs, and diuretics. So, because of the potential for nephrotoxicity, those RAS blockers must be monitored for side effects when starting therapy or within dose adjustments. ACE inhibitors, they should be used with caution in patients with decreased intravascular volume, suspected renal artery stenosis, sepsis, and concurrent use of NSAIDs, because these conditions basically here, they can cause acute kidney injury, also known as AKI. Women of childbearing age, they should be cautioned about the adverse effects of these medications on the fetus and should discontinue these medications if pregnancy does occur. A decline in GFR. If a decline in GFR occurs because the decrease in systemic pressure causes vasodilation of the efferent side of the glomerulus, leading to a decline in GFR and a decrease in serum creatinine levels. Therefore, we need to monitor the patient and say GFR frequently. Hypotension, we know, is basically usually dose related and can be ameliorated by slow dose titration and decreasing, let's say, the patient's dose. Hyperkalemia can be managed by decreasing potassium intake, using loop diuretics, correcting that metabolic acidosis, and using Locamer. Also, those ACEs or ARBs can be continued if the serum potassium level is less than 5.5. However, the incidence of, let's say, the cough due to angioneuric edema associated, say, with the class of antihypertensives is less than 1% and occurs frequently more common in the patients who are African Americans. Other drugs to consider that put patients with a GFR less than 60 at risk are going to be metformin, lithium, and digoxin. So metformin, you should be reviewed if in these patients with diabetes with a GFR between 30 and 44. So that's basic stage 3B. And it should be discontinued in people with a GFR less than 30, stages 4 and 5, because of potential for lactic acidosis. It is also recommended that all people taking lithium, that they should have their drug lithium level monitored regularly. Also, patients with GFR less than 60. So that's basically, once again, stages 3 to 3A to 5 who are undergoing a colonoscopy should not be prescribed that oral phosphate containing biopreparations because basically they're going to be at risk for a newly recognized form of AKI called phosphate nephropathy. So, who is at risk for progression? So, CKD more common in people aged 65 years or older than in people aged 45 to 64 years or those aged 18 to 44. CKD also more common in women than men. Also, CKD is more common in those non-Hispanic. Also, they say the blacks, the African Americans, and also those in the non-Hispanic. Also, in those that say who are not uh, non-Hispanic white individuals or non-Hispanic Asians. So looking at the disease, let's say related demographics and comorbidities, and understanding that there is overlap, let's say, amongst these patients, this chart here basically shows that diabetes and hypertension are the major causes of CKD in adults. Other risk factors, once again, will be heart disease, obesity, a family history of CKD, past damage to kidney to the kidneys, and also older age. So this chart here, it also shows the CKD prevalence by stages from year 2000 to year 2020. This KDIGO table, as you see, it basically lists the complications of CKD across the various GFR categories. So the color-coded visual, as you can see here, is going to be basically telling a story that in stage 3A, the range is from moderately increased risk in yellow to a very high risk in red for patients with that severely increased albuminuria, but with a GFR still considered to be only mildly to moderately decreased. So the majority of patients in stage 3B are at high to very high risk of progression and are likely to become symptomatic more rapidly. So basically in this CKD population, the kidneys now are working harder to compensate for deteriorating mass and function. And basically here we have the loss of kidney function going to be leading to complications of CKD as seen as on the previous slide. So we're going to say stage 3 CKD. So all of these here signs and symptoms need to be monitored for progression and treatment. So during the monitoring visit, symptoms are going to be assessed along, let's say, with lab testing. In stage 3B, the lab results will indicate increases in the serum creatinine and BUN levels due to a decrease in GFR, along with the possible reduction of hemoglobin and a slight increase in phosphorus as the patient say overall kidney mass and function is declining. So for some patients, we know the progression may be slow enough that they would not be aware of the changes that are going on and will continue, let's say, to function relatively normal. However, symptoms that may appear include fluid retention with lower leg edema, that possible uncontrolled fluctuation of blood sugars, elevated blood pressure greater than 140/90, changes in urination, or noted foamy urine, fatigue and being short of breath due to developing anemia, sleep disruptions, including difficulty to say falling asleep, muscle cramps, and or restless leg syndrome. And also, let's say your patient, they may complain, let's say, of a lack of appetite with subsequent loss of body mass. So in addition to continuing, let's say, to treat to slow the progression of that kidney disease, the focus of care when the patient GFR drops below 60 is going to be going to evaluate and treat the complications. Primarily, let's say, anemia, hypertension, which has already been discussed as a cause. Also got to think about, let's say, bone and mineral disease, acidosis, and also hypoalbuminuria. Speaking of nutritional assessment, it's going to be priority that we do a nutritional assessment. It's It's going to be necessary both as a baseline and for immediate diagnosis and also immediate treatment. Overall, a nutritional assessment is going to be extensive and dependent upon the patient's subjective findings. So referral to a renal dietitian is going to be recommended when the GFR drops below 45. Anemia, as you can see, is regarding clinical manifestation, going to be seeing a decrease in circulating red blood cell mass, usually detected by low blood hemoglobin concentration. Also, we know that erythropoietin hormone is produced mainly in the kidneys. However, when deficient, red blood cells are going to have a shorter lifespan and circulate in the bloodstream less effectively, and immature cells may be made and released that do not have the ability to carry enough iron to be absorbed by the rest of the patient's vital organ systems. Additionally, iron deficiency is going to be often present in patients with CKD, and they should be assessed if they are symptomatic. Therefore, annual evaluation of anemia should begin if the GFR, let's say, of 60. Also, speaking of guidelines, so the guidelines definition and identification regarding anemia and CKD in adults is going to be when the patient's hemoglobin concentration is less than 13 in males and less than 12 in females. So anemia can develop as early as stage 2. Assessing for symptoms such as fatigue, shortness of breath, poor appetite, muscle weakness with decreased cognition, and a decreased quality of life may lead to additional evaluation, beginning with the patient having a CBC level done. So basically your complete blood cell count level. Other possible causes of anemia may be, let's say, GI bleed, but it also must be assessed. So, as we know, anemia can be associated with poor outcomes in patients with CKD. Also, we know that low hemoglobin levels have been associated with increased hospitalizations, CVD, cognitive impairment, and an increase in morbidity and mortality. So, the key points for healthcare professionals to remember include doing the following: doing a workup for anemia in any patient who has CKD should include an assessment of secondary causes, including iron deficiency. Iron replacement is also going to be effective in anemia for patients who have CKD as initial therapy, and routes of administration, IV route or oral, will be determined by, let's say, the clinician and also the patient's preferences, and also those locally available resources in that patient's community or environment. ESA therapy. It should only be used when the patient is symptomatic and requires transfusion. Also, we know in most people with CKD, ESAs, those erythropoietin stimulating agents, they should not be used to intentionally increase the hemoglobin concentration above 11.5 and to not intentionally increase hemoglobin more than 13. ESA therapy is also not recommended for those with active malignancy or a recent history of malignancy. So the guidelines also recommend measuring serum levels of calcium, phosphate, parathyroid hormone, and alkaline phosphatase activity at least once in adults with a GFR less than 45 to determine those baseline values. So serum phosphate, calcium, and parathyroid concentrations are going to be interrelated in patients with CKD. Earlier phosphate control may help reduce the early clinical consequences of CKD, metabolic bone disease. So treatment is going to involve dietary control and using those phosphate binders, such as calcium carbonate, calcium acetate, sevelamer, or let's say other meds taken with meals. Also, people with intact parathyroid hormone levels above the upper normal limit of the assay are advised to be first evaluated for hyperphosphatemia, hypocalcemia, and vitamin D deficiency. So metabolic acidosis is going to be also a major disorder in CKD that can lead to poor health outcomes. So basically here is basically a acid-base disorder characterized by a fall in serum bicarbonate concentration. So in CKD, metabolic acidosis is going to occur when the bicarbonate is lost from the body via the kidneys. And when the kidneys begin to fail to regenerate bicarb through adequate acid excretion. So serum bicarb can be used to treat metabolic acidosis. So patients should be informed that the drug should be taken when and as prescribed so as not to interfere with the actions of other medications. So the KDIGO guidelines recommend that patients with CKD with serum bicarbonate concentrations less than 22 be given oral bicarbonate supplements. Now, unless contraindicated, the goal is going to be to maintain serum bicarbonate within the normal range. Also, treatment for metabolic acidosis decreases protein tissue breakdown. It's also going to improve their bone mineralization. However, untreated metabolic acidosis is going to become a serious complication. It's going to be leading to increased protein degradation and also the possibility of contributing to a nutritional compromise. Also, metabolic acidosis is going to be worsening regarding, say, the effects of the patient's bone disease. Fluid volume. It does not usually become an issue, however, in the early stages of CKD unless accompanied by the cardiovascular disease. So hypervolemia or fluid volume overload is going to be determined by the amount of fluid retained when water intake exceeds output. So edema can be present in the lower extremities, hands, abdomen, back, or face. A significant increase in blood pressure can occur with the presence of edema and can be accompanied by the patient, say, becoming short of breath. And also maybe think about if the patient who has CHF, congestive heart failure, is left untreated. Also, we know that low albumin levels and anemia are also contributing factors regarding, say, causes of edema in patients with CKD. Patients may be asked to record, let's say, their daily weights and compare, let's say, those readings to evaluate weight gain or weight loss and the effectiveness, let's say, of their diuretic therapy. So management going to include sodium reduction and sometimes fluid restriction in patients who have CKD. Also, we know that loop diuretics such as furosemide are going to be usually effective in volume control and also have the added benefit regarding assisting with potassium excretion. So the goal is trying to prevent heart failure and also subsequent hospitalization with ongoing volume assessment and early intervention. So speaking of, let's say, hyperkalemia, it's going to be one of the most serious complications of CKD. It can occur at any stage, but it's mostly seen in the later stages. It's related to the kidney's inability to actively excrete potassium. So ingesting, say, high potassium foods such as bananas, oranges, potatoes, tomatoes can cause high potassium levels. Other contributing causes may be the use of blood pressure medications such as ACEs or ARBs, and to a lesser extent, beta blockers. Also, we know hemolysis caused by blood loss or transfusion may also cause elevated potassium levels. It's also important to verify the patient's serum potassium level by repeating, let's say, the lab test when the when the specimen is labeled as hemolyzed by the lab, because here potassium level may be falsely elevated. EKG changes, they can and do occur and include those tall tinted T waves, a prolonged QR interval, or a widening of the QRS complex as potassium level, let's say, gets higher. Elevated potassium levels can cause muscle tenderness and also muscle weakness. Nutrition counseling also stresses that low potassium intake is going to be very, very essential. It's going to be careful monitoring regarding, say, our patient's potassium level after initiation regarding, say, of an ACE or R, but also, let's say, increasing, say, the dose of an ACE or R. Adherence to, say, to the patient's medication management strategies should also be encouraged so that the hyperkalemia can be avoided and the patient can remain on that ACE or R for kidney function protection. So, nephrology must be consulted to establish the diagnosis of CKD. The nephrologist may also already, however, be involved in the care of the patient with known kidney disease. For example, a person, let's say, with PKD, polycystic kidney disease, with normal kidney function, they may be seeing a kidney specialist once or twice a year. The nephrology team may also include, let's say, physicians, advanced practice nurses, or physician assistants, staff nurses, dietitians, and social workers. In most cases, though, the primary care provider, called the PCP, is going to be continuing to care for the patient, incorporating these key guidelines from the nephrology team. The consulting nephrology team will summarize, let's say, these findings, recommend treatment, and or follow-up care for the patient to take to their primary care provider. So primary care provider, as we know, as mentioned before, may be a physician or advanced practice nurse or a physician assistant, may perform screening and management, including CKD and cardiovascular risk reduction. A dietitian may also be involved in nutrition management in cases of diabetes and hypertension. A social worker may be or may not be involved at this stage, but may be consulted if financial issues become a concern, especially regarding, say, the patient able to obtain their prescriptions, medications, and or difficulties, say, trying to cope with regarding all these increasing demands of, let's say, this progressive kidney disease. Also, registered nurses are going to be involved in patient education and monitor response to the patient's therapy. So, nephrology nurses, we're going to be using the nursing process to care for patients with kidney disease. So this slide here, it highlights, as you can see, key resources and references to use. So, as you can see, quoted by Novak et al., self-management involves active participation of the patients in the everyday care of the symptoms of their illness or illnesses and medical treatments, as well as maintaining general health and prevention of progression of medical conditions. So, concerning CKD, self-management requires learning new skills, including changing behaviors, managing medical aspects, and interpreting and reporting those key symptoms. Other skills that may be required are learning to seek out and use resources effectively and establishing a relationship with the healthcare provider. Successful management of CKD is going to also require the patient recognizes with the help of the family and also their friends that he or she is the principal manager regarding this chronic disease. So we need to be teaching the patient what the lab tests are for and how to interpret these key lab results. Teaching them also regarding how to save their veins by requesting that blood be drawn only when necessary and in for regarding veins, regarding is so from veins, especially on the back of their hands. Teaching the patient to assess fluid status by observing blood pressure readings, peripheral edema, and also body weight. Also, for our patients regarding self-management, make sure that we review with patients with diabetes their practice of the monitoring and management of their blood sugars through medication, also diet. Educate the patient, say, regarding reviewing with them, especially patients who have hypertension, about medication, diet, physical activity, and also blood pressure awareness. Educate about the importance of age-appropriate vaccinations against any viral illness that is not to be overlooked in preventive care. Also educating them on providing guidance and reporting symptoms to the healthcare provider, and encouraging those key lifestyle modifications. Of primary importance in regarding lifestyle modification is going to be smoking cessation. So nicotine accumulation is going to be higher in an individual with kidney disease, and it's going to be leading to increase with declining kidney function. So smoking, it can affect glomerular structure and function, and it's going to be independent risk factor for the progression of albuminuria. Increasing physical activity, especially walking, promotes weight loss, lowers blood pressure, increases cardiovascular health, promotes restful sleep, and may strengthen, let's say, the patient's immune system. So numerous well-based resources are going to be available to educate, let's say, the patient about the benefits of lifestyle modifications for CKD and for their overall general well-being. So, speaking of, let's say, continuing management. So, a dietitian, they can supply specific diets for patients needing glycemic control and diets to limit phosphorus and potassium. But all patients, especially those with hypertension, can benefit from a low to moderate sodium restricted diet to control blood pressure and also anemia. So, think about suggesting flavoring foods with fresh herbs, garlic, lemon juice, or a salt free seasoning such as Mrs. Dash. However, though, need to be mindful that regarding using salt substitutes because they can, however, they contain a high potassium content. But most importantly, let the patient know to be taught the need to read their food labels for processed and fast food for that hidden sodium and also that hidden phosphorus. Regarding medication management, some helpful strategies for that are going to be using pharmaceutical agents that can be taken once daily to enhance adherence to prescribed therapy. Also, we want to discuss with the patient what strategies such as daily pill containers, reminder magnets, and also written medication lists that can help them keep track of the time regarding taking their medications. Also encourage them the use of these inexpensive ways to remember taking their pills. Last but not least, patients should be encouraged to use just one pharmacy for all their medications. Once again, one pharmacy for all their medications. Because, hey, we're trying to prevent those errors, such as duplication of drugs or class of drugs and those drug to drug interactions. So, a wide array of printed brochures and books is available for various resources, including renal related organizations from pharmaceutical companies and governmental agencies. So, the internet is going to offer numerous resources, most of which can be downloaded for printing. And these here include simple explanations of normal and altered kidney function, strategies for protecting the kidney, and kidney friendly recipes. So, the National Kidney Foundation Kidney Early Evaluation Program, also known as KEEP, is going to help to increase the awareness of kidney disease, and it's going to be offering free screening to at risk populations. So, in summary, what kidney function a patient loses from CKD cannot be regenerated. The loss is permanent. Treatment in stages 1 and 2 effectively stops the disease process. Proper treatment and diet changes, we know, can slow the progression of stages 3A and 3B. And we also know that continued lifestyle changes, including routine PCP visits and blood and urine testing, are going to be needed to help the patient manage CKD disease and also comorbidities. Additionally, appropriate referrals to an interdisciplinary team, a cardiovascular specialist, or a dietitian in the early stages of CKD can help control the cardiovascular risks that are so highly prevalent in this population. So perhaps most importantly, early detection It's going to lead to early interventions to slow disease progress and minimize complications. Still, it also allows the patient to take full charge and also self-manage their disease while they are physically and psychologically well enough to do so. Late referral to the interdisciplinary team means little or no patient education about treatment options and empowerment to self-manage care. So please see the next one, module 3, to learn about chronic kidney disease stages 4 and 5, overview of kidney replacement therapy options. So for the CKD modules, as you can see, please see other modules on the ANNA website for more information on chronic kidney disease and kidney replacement therapies in adults and children. So I'd like to thank you for the care you have given the patient with CKD, kidney failure, and for choosing to learn more about them and their therapies through these CKD modules. As a reminder, you can download from the online library a PDF copy of these slides, a printed narrative, references, and resources, and a link to the glossary of terms. I would definitely like to acknowledge, let's say, the individuals and authors and reviewers for the CKD modules. And definitely want to give thanks to Miss Leslie Dinwiddie regarding the whole collaboration of the people regarding CKD modules. So thank you, Leslie. Here are the key references used in this slide presentation. And for more information about CKD care and about ANNA, please visit our website and the online library. Thank you.